Bu oturumda cerrahları nasıl kurtarırız çalışmalarında medikal sanayinin bize bir hediyesi olan sinir monitörizasyonu ile ilgili bir konuşma yapacak Doktor Lorenzo. Biz son birkaç seneden beri bunu kullanıyoruz. Artık Avrupa'da sinir monitörizasyonu kulüpleri kuruldu ve bu kulüpler işte 2 ayda bir, 3 ayda bir bazı özel hastanelerde, ki en son ben de Komo'da bulundum. Orada bir toplantıya katıldık ve sadece sinir monitörizasyonu ve sinir tamirleriyle ilgili bir toplantı yapıldı. Tabii ki Amerika'da bu çok fazla kullanılıyor. Bir hafta önce oradaydık. Artık onlar sinir monitörizasyonu olmadan tiroid ameliyatları yapmıyorlar. Çünkü biliyorsunuz ki hastanın sesi kısıldığı zaman ömür boyu bir mahkumiyeti var. Bu mahkumiyetinin cezasının bir kısmını cerraha çektirmek istiyor. Bu bakımdan sinir monitörizasyonu Amerika'da bizden çok daha fazla kullanılıyor. İlk çıktığı zaman otorlarla konuştuğumuzda eğer sinir eksplorasyonu bilmeyen bir cerrah sinir monitörizasyonu kullansa dahi hasarı engellemesi mümkün değil. Bir ikincisi, nasıl olsa sinir monitörizasyonu var, ben her yere gireyim dediği zaman da yine kazalara sebep olabiliyor. Bunu önlemenin yollarını Doktor Dionigi bize anlatacak. Kendisi Insubria, İtalya'da genel cerrahi direktörü. Böyle bu kendi tecrübelerini bize aktarmaya çalışacak. Biz de bunlardan bir şey yapabilsek ne mutlu bize. Doktor Dionigi, please.
Again, thank you very much for this kind invitation. For me, this is the first time in Turkey, so I really appreciate this visit. So, aim of this presentation, of the second presentation, I will present a review and update on intraoperative neuromonitoring, and I will try to answer to this question: if neuromonitoring is needed today in the modern era of thyroid surgery. This is my disclosure. I have any relationship with any company with intraoperative neuromonitoring. So, first of all, I would like to explain you that the gold standard of thyroid surgery today is not neuromonitoring. The gold standard today for thyroidectomy is still identification, routine identification of the recurrent nerve, is always exposure of the recurrent nerve, is experience, training, and always perform pre- and post-operative laryngoscopy. Pre-laryngoscopy is important to detect any abnormality before surgery. Post-operative laryngoscopy, we perform to all cases post-operative laryngoscopy. This is important for our personal audit, to know what's the quality of our surgical procedure. So, why neuromonitoring? Recurrent nerve and laryngeal anatomy are the basis of thyroid surgery. Why we do need more than anatomical nerve identification? So this is the right question. And this is an example where we have, this was a routine thyroidectomy, really little goiter, routine case, and the only way to appreciate all this structure was to add not only vision to the nerve, but only add another dimension intraoperatively, which is to test the function of each of these structures. So here we have a signal. Here we can, if we stimulate this branch, we can see the esophageal, cervical esophageal twitching. Here we have a signal. This is the anterior branch of the recurrent laryngeal nerve going inside the larynx, and we have a signal. Here we do not have a signal. This is the posterior branch of the recurrent laryngeal nerve. We don't have the signal, and of course here we don't have the signal. These are branches of the inferior thyroid artery. So again, the first message is that with intraoperative neuromonitoring we can both identify the nerve both visually and confirm it electrically. The second point, I will give you another example, intraoperative example, is this one. This appears to our eyes like a very nice nerve at the end of our surgical procedure, but believe me, this is an injured nerve. This nerve is not working. If we test the vagal nerve or if we test the recurrent nerve here, we don't have the signal. This nerve is not working. And by pinpointing the nerve with the stimulator, we don't have the signal till here, and here we have the signal. So this is, we can map the nerve and see where is the nerve injured, where is injured. So with intraoperative neuromonitoring, we can evidence if the nerve is injured in every case. And going back to the literature, it is important to remember that the intraoperative evidence of an injury to the recurrent nerve is very low. Even the surgeons were very famous surgeons, very experienced surgeons. Their attitude to understand and to rely if the nerve was injured or not is very low. It is between 7.5 to 15 cases. It means that just one case of 10, they rely that the nerve is injured. Okay, and these are all very experienced surgeons. This is the important thing. Anatomical nerve lesions are only exceptional reason of post-operative palsy. Most of the injury to the recurrent nerve are not anatomical, are not visible to the surgeon eye because they are stretch injury, traction injury, compression injury, and the nerve is anatomically intact. Okay, most of the cases. In fact, the causes of nerve injury are several, like section, ligature, or mistaken hemostasis in dissection. And in these three cases, the surgeon can understand if the nerve is not working, is injured. But most of the cases, like traction injury, compression, thermal, and ischemia, the only way to understand if the nerve is working is with intraoperative neuromonitoring. And believe me, the thermal and electrical injury, according to the last studies, are increasing due to the more and more use of energy-based device, okay, which can give thermal injury which are not visible to the surgeon eye. If we analyze the literature, this is the famous work by Chang. Well, according to his experience, in 93% of cases, the injury was a traction injury, stretch injury, and all this injury, the surgeon could not realize with his eye that the nerve was injured. This is another experience in 2008 by the group van Snyder. Again, according to this study, in 68% of the cases where a traction injury or compression injury, in all these cases, the nerve appeared very nice. Only with neuromonitoring we could test if the nerve was working or not. And this is our personal experience with endoscopic thyroidectomy. Well, according to our experience, in 93% of the cases, the nerve is very nice, but is not working, is injured. And the causes of injury are traction or thermal injury. So, another why we use intraoperative neuromonitoring. This is one of the many cases my endocrinologist sent me. This is a recurrent, was operated with me and Dr. Chang, recurrent Graves' disease. Well, by increasing the amplitude, the signal, by increasing we have a signal, and under this signal we can identify the nerve. So another benefit of intraoperative neuromonitoring is identification of the recurrent nerve, and as you know, your thyroid surgery, the earliest and the definitive identification of the recurrent nerve gives protection to the nerve. More early is the identification, and more precise and definitive is the identification, and the nerve can be, there is less traction to the nerve, less compression to the nerve. And as you can know from the literature, as a previous case, which was a recurrent goiter is considered in this multivariate analysis a matter of increased nerve injury rate. This is another case why we should use intraoperative neuromonitoring. In almost 60, 70, also in some cases 80% of the case, the recurrent laryngeal nerve have two branches, sometimes are three branches. One, the ventral one, usually is the motor one. The posterior is the sensory one. The motor one has a signal. The posterior one has no signal with intraoperative neuromonitoring. This is an easy case, but in the case of this bifurcation, very proximal, and the surgeon, during the tiroidectomy, the first branch he identifies is this, and he thinks this is the final recurrent nerve and doesn't test, he will ligate probably the upper one. So with intraoperative neuromonitoring, I will not have the signal here, so I will try to find the second branch, the ventral branch, which is the motor branch. Okay? So branch identification, and this review of branching of the recurrent nerve, as you can see, there is from 60 to 80%. It depends when you go in to measure the entrance of the recurrent nerve, so it's a high prevalence. And we know that branches is one of the most common causes of injury to the recurrent nerve, or is a risk factor for transient vocal cord palsy. And according to this recent publication with intraoperative neuromonitoring, there is a significant higher rate of identification of branches. This has been published in 2011 by the group by Barczyński from Poland. But the big question today is, does intraoperative neuromonitoring give protection to the recurrent nerve in terms of less palsy, less transient or definitive palsy? It is quite difficult to build a prospective randomized trial because you need a number, as I told you yesterday, a number of nerve at risk. Professor Drale calculated for benign disease you need 4 million nerve at risk. For malignant disease you need 34,000 nerve at risk. So it's quite difficult. Moreover, patients, at least in my clinic, will not accept such a randomization. They do prefer neuromonitoring, as well as will be quite difficult to say to a center, you don't have to use neuromonitoring. While according to the literature, there is many papers. I will show you this paper again from the group from Barczyński, was published by the British Journal of Surgery in 2009. According to this study, in high-risk population, nerve monitoring, especially for transient, was a statistically significant reduced risk of nerve injury. So only high risk and only transient. There was no benefit for permanent and low risk procedure. High risk procedure were Graves' disease, cancer recurrence, and central compartment lymphadenectomy. We performed, this will be published this year, a meta-analysis. This is an update meta-analysis on recurrent nerve monitoring from 2012, February in 1994. These are all the inclusion and exclusion criteria. This is the flow chart. We selected 22 publications and the only good studies were only 8, perhaps. These are the studies, the one by Brakov, and for a total, some were randomized, some other were not randomized, for a total of 5,000 nerve at risk. Well, according to this update meta-analysis, there is significant protection with intraoperative neuromonitoring. It is significant only for transient recurrent nerve palsy, according to this meta-analysis, update meta-analysis, while we did not find any significance for permanent injury of the recurrent nerve with intraoperative neuromonitoring. Another reason why I do use intraoperative neuromonitoring is the fact that I must say you that often, especially in Italy, not abroad, many surgeons come up and say, I don't need intraoperative neuromonitoring because my palsy rate is 0. Okay? Why is 0? I ask him. Probably he is in this group. So what I want to say that if you routinely perform laryngeal exam to all your surgical population, and this is a very good work from Hong Kong University, the overall palsy rate is 7%. It could be 12% in difficult cases. In this study, on the first day post-operative, they do laryngeal exam. While if you do not perform a laryngoscopy to all your patients, but only if they are symptomatic, the rate is 0.3. So the other point, the true audit, the true incident of the recurrent nerve is higher than the one has been published in the last 20, 30 years. But the turning point, this was discussed yesterday, especially with Henning Dralle. I really believe that the difference between intraoperative neuromonitoring and visualization, and only visualization of the nerve, is the fact that with neuromonitoring today we can change our strategy intraoperatively. And I will try to explain it. This is the famous paper published on World Journal of Surgery in 2010 by the group from Professor Gorensky. Well, he analyzed 36 loss of signal at the first lobe. It means he always starts from the dominant side. If he had a loss of signal at the first side, he decided. In 16 cases, he unchanged his strategy and he continued to do also bilateral surgery to the other side. And in this population, he had almost 20% of bilateral palsy, while in the other 20 loss of signal at the first side, he decided to change a strategy, and of course he had 0 bilateral palsy. This is important, especially for bilateral benign goiter. And recently, this year, Henning Dralle published this survey on intraoperative neuromonitoring and asking surgeons, this was thousands of surgeons in Germany, their willingness to change surgical plan after unilateral loss of signal. And interestingly, between 70 to almost more than 90% of the surgeons, knowing that loss of signal at the first side, they will stop the procedure in Germany. And interestingly, surgeons with high volume procedure, more than 200 thyroidectomy per year, they were the one that will stop the procedure after first side with loss of signal. The other changing of strategy, this is another important topic, is intraoperative corticosteroids. According to this study by Wang from Taiwan, the group from Chang, knowing intraoperatively with intraoperative neuromonitor that there is a redux signal to the nerve is on stress, they will give in this population intraoperative cortisone, while in this other population they did not give intraoperative cortisone. Okay? Well, there is no difference in the number of palsy between the group, but the restitution time, the recovery of these nerves is more precocious. Okay, this population, and this was significant. The nerve returned to normal activity weeks before the other group. So, what are the implications of a loss of signal with intraoperative neuromonitoring? First, I would like to explain you that stage thyroidectomy, it means to stop the procedure when you have a loss of signal. This is not a new criteria. It was for the first time described by Pemberton in 1910 and before by Luigi Porta in 1889. They well describe in the case report that they understand during their surgical procedure that they cut the nerve, and so they decided not to go to the other side and to postpone the other side in other months. And there are other reports from Japan about stage thyroidectomy. The other important consequence, implication of a loss of signal is the consent, the informed consent to the patient. In our clinic, we have to explain to our patient that we will do thyroidectomy with intraoperative neuromonitoring without giving too much emphasis of neuromonitoring, because we have still palsy with neuromonitoring. But what is important to explain our patients the possibility of staging the procedure. And believe me, they recognize this benefit of staging the procedure. But this is important to tell to your patient when you are using the intraoperative neuromonitoring. Always explain the consequence by using the intraoperative neuromonitoring. The other important consequence, you should start always to the dominant side. In Italy, this is not so common. There are some surgeons starting always to the left side or always to the left side. It is important to start to the dominant side. It means where is the cancer, where is the toxic nodule, where is the adenoma. Then I already spoke about intraoperative steroids. Of course, if you see the nerve injury, and this is injury, you can map the nerve, see what is injury, and if it's a clip or is a stricture, you can release the clip or the stricture, and the palsy can become from permanent to transient. But also, what is important in staging a surgical procedure, this must be a multidisciplinary decision, because if the patient is very old with a lot of comorbidity, the anesthesiologist, you have to speak with your anesthesiologist, and the anesthesiologist says, well, I'm not happy to bring her again in the operating room, so you must interact with your anesthesiologist. But you must interact also with your endocrinologist. This is an example. We have about 25 staging thyroidectomies. We have 2 Graves' disease. After completion of the first side and the hysterectomy, we had the loss of signal. And the remaining side was not operated because the volume was little, and the patient and endocrinologist and I decided to ablate the remnant side. So it is staging, it is an important multidisciplinary decision. Also, the other implication when to perform contralateral surgery, and this is when there is a restitution of the recurrent nerve and other benefits after speech therapy. But if the surgeon doesn't stage and he wants to continue the surgical procedure, I always suggest to report in the patient charts why he did it. And I believe this can be a matter of discussion, that there is no guidelines of a loss of signal when there is a cancer patient. This can be better, we should develop this with our international study group of neuromonitoring. And the other implication of a loss of signal, this is important, you must check this is a true loss of signal. And they have been published 2 guidelines of intraoperative neuromonitoring. You have to look to our troubleshooting algorithms and be sure with this algorithm, this has been published, that is a true loss of signal. And this can be made by laryngeal twitch and contralateral vagus nerve stimulation. So why neuromonitoring? Personally, the answer is very simple. Because the frequency of vocal cord dysfunction is more common than expected. Anatomic nerve lesions are only exceptional reason of vocal cord palsy. Most of the injury to the recurrent nerve are not visible as stretch injuries. And I really believe neuromonitoring provides a safer surgery, especially for staging thyroidectomy. Moreover, there are other benefits, I must say. We published this year this paper on World Journal of Surgery. According to this study, we analyze the non-recurrent nerve. According to this study, the rate of non-recurrent laryngeal nerve was higher when using the intraoperative neuromonitor, according to the other period where we were not using intraoperative neuromonitor. And this is an example of last month. The other benefit by using intraoperative neuromonitor, this has been recently published by the group again from Barczynski, and according to this study, there is an increased prevalence of identification of the external branch of the superior laryngeal nerve, especially the type 1 and also the type 2 and the type 2B, all types of Czernia nerves. Recently, this is an additional review. This was published again this year on thyroid. According to this study, the no use of intraoperative neuromonitor was associated with more upper digestive symptoms. This is probably because with intraoperative neuromonitor you can appreciate all the nerves going also to the esophagus and save them. So you can, probably this is the reason of these results. I've been criticized many years because I like to give the stimulator to my residents, but I really believe that neuromonitor for residents and also for low experienced surgeon is important because they can incorporate a new technology. Is a great teaching aid because they can appreciate not only the normal anatomy but also the neurophysiology and physiopathology of the recurrent nerve. They can elucidate the errors, they can understand where they mistake, where was the mistake, when they injured the nerve. And as you know, Tralle published in 2004 this paper where in less experienced surgery intraoperative neuromonitor decreased palsy rate of the recurrent nerve. And we know that experience of the surgeon and hospital volume is a matter of high risk of recurrent nerve palsy. As I told you till now, I really believe that the most important elements for intraoperative neuromonitoring is in the clinical practice. The medical legal, in my opinion, comes afterwards. Even if in the world, especially in USA and in Germany, now medical legal issues and neuromonitoring have important interaction. While for the medical legal issues, with intraoperative neuromonitor we can bring to zero the bilateral recurrent nerve palsy. But what is important in the modern era of general surgery, the most important thing is documentation. We document with videos the lap cholecystectomy, we document colorectal surgery with our video, we document with video and pictures breast surgery. With intraoperative neuromonitor we can document all the surgical procedure of the recurrent nerve. And in this way we can early differentiate between recurrent nerve related and unrelated voice changes. And the other topic for medical legal issue, as was pointed out yesterday, is the fact that now neuromonitoring is becoming the new standard of care. And this is the survey in Germany where a total surgical clinics performing thyroidectomy were 1,200. About 86% are equipped with intraoperative neuromonitoring, and in 76% of cases they use it in all cases. So this is in Germany. And what about Italy? We don't have the numbers of Germany, but the curve is increasing. In 2011, we did 2,500 thyroidectomy with intraoperative neuromonitoring, and only in August of this year we're already 2,100. So I believe it's increasing, as well as increasing in Taiwan, Japan, China as well. Why is increasing? The prevalence, there are several reasons, because now we have a non-invasive device with the tube. There are some evidence from randomized trials. There are finally guidelines of standardization, the one published by Laryngoscope, some medical legal issues, the one published by Peter Angelos, some research. I must say a great commercial effort, but be careful of commercial effort, I must say, be careful. And I know that in Poland, in Germany, in Italy, and briefly in USA, society will recommend intraoperative neuromonitoring. How? This is a very difficult topic. They will recommend that high-volume centers must have intraoperative neuromonitoring. The intraoperative neuromonitoring should be used in selected cases, okay, in difficult cases, for example, and they should, or all the society should recommend training courses to explain surgeons, thyroid surgery, how to use well with standardization the intraoperative neuromonitoring. This is the three important topics. And this is our paper on the guidelines. I would suggest you to read it with all the standardization of intraoperative neuromonitoring. The aim of this paper was to improve the quality of intraoperative neuromonitoring, to improve the accuracy, the validity of the signals, the specificity. According to our guidelines, always perform laryngoscopy, exclude those devices with audio-only systems. They are very old systems. There are a standardization of the equipment, of anesthesia, how to position the tube, the optimal level of stimulation, the EMG data interpretation, the definition of the signal, evaluation of surgical strategy. But what is important to put in the mind of a thyroid surgeon is to stimulate the vagal nerve. If you stimulate the vagal nerve before any dissection, it tells you that the device is working. If you test the vagal nerve at the end of the surgical procedure and you have the signal, in 99.7% of the cases the nerve is intact. So vagal nerve is important, and has well been described, vagal nerve stimulation against only recurrent nerve stimulation increase the validity of the signal we have. And again in Germany, in 2000 vagal nerve stimulation was about 70% of all thyroid procedure. In 2010 is 90%. So vagal nerve stimulation is increasing as well. So my personal conclusion, okay, so there are several important limits of intraoperative neuromonitoring that I did not speak about. First is the fact that we still have palsy to recurrent nerve. This is the topic. You don't have to tell a lie to your patient that with intraoperative neuromonitoring you have zero complication. This is not true. The data from the literature is clear. My personal rate is 4.7. So I will tell my patient my rate is 4.7. I don't tell my patient it's 0. Okay. The other lack, there is not so standardized procedure. Few surgeons know the most common pitfalls. Few surgeons know the troubleshooting algorithms. Intraoperative neuromonitoring does not replace a clinical judgment. In case the device doesn't work, you must perform a traditional thyroidectomy without intraoperative neuromonitoring. Costs. We need more study on the neurophysiology of the recurrent nerve and the superior laryngeal nerve as well. And there is no data of thyroidectomy performed in local anesthesia. And this has been described in Annals of Surgery. So briefly, I try to explain you that We have several implications of intraoperative neuromonitoring in clinical practice. It is a great instrument for research, for neurophysiology, neurophysiopathology. It's a great instrument for education and has some medical legal issues. And if we analyze the risk factors for recurrent nerve palsy, with intraoperative neuromonitoring you can identify variations of the nerve. You can help tiroidectomy in case of difficult cases, Graves' disease, recurrent nerve. You can, intraoperative neuromonitoring helps, for example, in a central compartment lymphadenectomy, and as I told you before, in low experienced surgeons, it has been well described, it helps. So, and perhaps modern surgery is eradication of disease, safety of the procedure, but especially documentation. And with intraoperative neuromonitoring, you can have documentation throughout all the surgical procedure. Thank you very much.